So as PIH Malawi, we're implementing a community health workers model program, which is more or less standalone from what the Malawi Ministry of Health implements, and it's called household model. So under the household model, CHTs basically help in ensuring screening for early detection of disease conditions, as well as linkage to a facility for people that have been screened from the community and seem to have a potential of specific disease conditions to ensure that they're linked to care. So for the CHT program in Malawi, we have a total of 1,233 community health workers in the North District. And these are across 14 healthy facilities that PIH Malawi is also supporting in the North District. The household model program itself dates back from 2017, which was a shift from what used to be patient-focused model that started being implemented in 2007. But come 2018, PIH Malawi partnered with Medic Mobile to develop an application that is used by these community health workers to ensure that it supports them in the tasks that they do monthly. So we call this application in the NAFE, and that's the local or native name that it is known by. Basically, the program aims to improve workforce as well as monitor progress towards universal coverage. And since utilization of this digital application, it has also helped in access to data in real time. So like I previously mentioned, we have a total of 14 facilities that we're supporting in, as partners in health. And of these 14 facilities, at the moment, seven of these are currently using the NAFE application. So that basically represents 50% coverage. And also from the total of 1,133 CHTs that we have, we've currently trained and equipped 629 community health workers, which is approximately 51%. So 51% of these CHTs are currently using the NAFE application for delivering their work. So at the moment, we are also exploring on integrating the NAFE application with OpenMRS, a data management system that we use in the North District. And through this application, CHW is supporting community members in disease conditions, including NCDs, HIV, TB, family planning, issues to do with maternal health, where we focus more on pregnancy, antenatal care, as well as postnatal care, and also child health and pediatric malnutrition. What is on the other side is basically the interface of the NAFE app that we're using.
So in this slide, I'll be presenting on the people, the personas who are working on the HIV workflow and the CHT hierarchy for the specific HIV workflow. So at the community level, we have community health workers and senior community health workers who are offline users in CHT, meaning that they can collect data offline, but they still need to sync their reports. So their main work in the HIV workflow is that they create HIV awareness and sensitization in their community. So as they visit the households, they will talk about HIV and the need for HIV testing. So they use the CHT application to do guided screening and referral of eligible cases. So anyone who has never been tested or was tested more than 3 months ago, they are referred to the health facility for testing. So the community health workers and senior community health workers also help to link people who are HIV positive to care. So if they find somebody who is HIV positive in their community, they will refer them to the health facility so that they can begin their care. Then The CHWs will also follow up people who are already on HIV treatment. So anyone who is 1 year and below on HIV treatment is followed up daily, and anyone who is above 1 year is followed up monthly. And this is for adherence counseling and making sure that they get to attend their clinics. CHWs are also involved in defaulter follow-up. So anyone who has defaulted their clinics, the CHWs will follow them up. Then we also have site supervisors, and these are found at the facility level, and in CHT, they are admin users. So their work in the HIV workflow is that they link ART patients with CHWs. So anyone who is found at the facility, they are linked to the CHWs for follow-up. They also link treatment defaulters with the senior CHWs, and CHWs are for follow-up. And then they also conduct guided supervision and mentorship for CHWs. So they will observe CHWs as they visit the households and provide any mentorship based on any gaps that have been identified. Then they also do performance management because they're able to see how the CHWs are performing, and this can be found in the dashboards. Lastly, we have the PIH program staff. We have a number of them, and they're all based in PIH offices. We have given them a role in CHT as admin officers, but their work is mainly to monitor program-based indicators through dashboards, so they can still be able to see everything that is happening on CHT.
I'll be taking us through what the CHWs do on the ground, and I'll share my screen. This is the interface for the community health toolkit that the CHWs see when they log in. And in our profile, we are the CHT Roundup CHW assigned to CHT Roundup area. On the left-hand side, you'll see a household. In the Chichewa language, household is called Banja. So Banja la Jafton means household of Jafton. When the CHW visits this household, they'll access the details by selecting it, and then they can get inside it and see the people who are registered. So this household has just one person, and each month the CHW does a monthly screening. So when they interview a particular patient, they'll go into their profile, and then they'll go to the new action button at the bottom of the screen, and they'll select the over 5 monthly screening. You can see that we also have other forms if the patient, let's say, died or they've moved away. In our case, we'll select the over 5 monthly screening. And this screening form starts off with some instructions relating to COVID. These are just precautions that the CHW needs to take. And then on the next page, they'll see the eligible workflows that the patient can be screened for. So in our case, we have TB, HIV, NCD, and hospitalization. For this demo, we'll be focusing on HIV. So the sections will be displayed in order that we had them in the previous page. So we'll start off with TB. And for the first question, we'll say the patient hasn't been enrolled in a TB program since the last visit, and they're not showing any symptoms. Next, we go into the HIV screening section. We'll say that the patient has not been enrolled in ART program since the last visit, and they have never been tested. Next section, we'll have the NCD screening section. The patient hasn't been enrolled in NCD program since the last visit, and they're not showing any of these symptoms. And finally, we have the hospitalization section. We'll say the patient hasn't been hospitalized. So at the very end of the form, the CHW is shown a summary of the details that they input, and they can go back and review any of the details that they've entered. So under the HIV screening section, you will notice that we have these 2 items of information. One, that the patient has never been tested, and 2, they have been referred the instruction to the CHW is to refer the patient to the health facility for HIV testing. So we'll say, yes, the patient has been referred, and then we'll go ahead and submit the form. So after submitting the form, the CHW will get a task that is activated to follow up with the patient for the referral that they've recommended to the patient. So we'll assume a few days have gone by, and each morning the CHW starts by visiting the tasks tab of the application. So this shows upcoming duties that are supposed to be performed. So in our case, we have a HIV testing referral follow-up. We'll assume in the meantime, the patient had a chance to visit the facility and get tested, and now they're back at home. So the CHW finds them sometime later. So when the CHW clicks on the task, they'll get the accompanying form, and they'll say the patient visited the facility, they had a HIV test done, the test was positive, let's say, and the patient has been initiated on treatment. To keep things simple, it'll say there is no EMR ID available. And yes, the patient was given a return date of next week. And then same thing, we'll see a summary page. In case the CHW made a mistake, they can go back and edit. So they submit that form. And when we go back to the patient profile, we'll notice that the information that we've entered is reflected, that the patient is in the ART program, but the ID is not available. So that's what happens for patients who have attended the referral follow-up. We also have another scenario where a patient can just go to the facility without the actual referral being without the referral coming from the CHW. So I'll switch over quickly to the site supervisor profile so that we can see how that profile, how that workflow works. So the site supervisor mostly sits at the health facility level, and it's possible that a patient can visit the health facility without being intercepted by the CHW. Let's say they leave early for work and they come back late. So when they visit the health facility, it's the responsibility of the site supervisor to capture the details when the patient has been admitted to the ART program. So the way they'll do that is by filling out a treatment enrollment form. And this form has different kinds of conditions that the patient can be subscribed to. We have TB, we have ART, we have NCD, and also malnutrition. So in our case, we're interested in ART. Same thing as last time, we'll say the EMR ID details are not available. And then the patient can be enrolled through that route, through that alternative route from the treatment enrollment form. So the last aspect I'd love to share is about defaulter tracing. This starts from the site supervisor level. So I'll go back into that profile, and it's possible that a patient could have visited, let's say, a different facility where they are not known or they have migrated into. So the site supervisor, upon noticing that they need to be traced, they'll submit a trace report. So this report is for different kinds of conditions. We are interested in NCD in this case, and they'll be prompted to enter the date of the missed appointment and when the patient should visit the facility. So this form is very short. Once it's submitted, the patient can be traced by the CHW. So I'll switch over quickly into the CHW profile so that you can see how they are prompted for that information. Now we are back at the CHW profile, and on a different day, they access their tasks tab. They're supposed to sync so that they can get details. And for this case, because the patient had been previously enrolled into the ART program, we get a daily referral follow-up. As Jennifer mentioned, that ART patients who are less than 1 year old, they get daily follow-ups. Patients who are more than 1 year old in the program, they'll get monthly follow-ups. So that is how the workflow is set up.
On the challenges, like I mentioned earlier during the introduction, we're working with CHWs that are not really, that are more or less like volunteers. And in terms of the literacy levels, most of them, they have like low literacy levels. I think for some, the highest should be upper secondary level education. So this has sort of been a challenge in terms of utilization of the app, because most of these are not tech savvy. But of course, with trainings and continuous mentorship, they sort of they improve. And then another issue that is another issue is on data quality related issues. So on this, it comes from both ends. It's from the app itself and also the ability of the CHW sometimes to input the data in the application. So sometimes CHWs would erroneously input data in the app, and also because of some bugs that require fixing in the application, it also affects the data outcomes from it, which overall influences the data quality. Yes. On app design and workflow gaps, we experienced challenges in terms of some of the workflows and how they were designed, like the expectation of how we want them to actually work in the community, and how the app really performs. Like for example, I think Elijah just mentioned about how we follow through clients on ART their first year. We expect to follow them daily, and also for clients that have stayed in ART for say more than a year, we expect to follow them monthly. Sometimes we'll have say a client that has been on ART for more than a year, having the daily follow-up form appearing on their profile, and then vice versa happens. But then these are things that we're continuously working on as a team, and they've been very keen helping us determining some other innovative ways of how we can improve the application and its performance. And the other issue is also there isn't really a proper linkage between the community level data that we're collecting for the application and the facility level data that is also being collected at the facility level. And that's one of the reasons why also, as I mentioned, to say we're sort of exploring if this application can be integrated with what we use as PIH Malawi for data management at facility level. In terms of impact and lessons that we've learned so far, one key highlight has been on improved supervision for CHWs. Since we started using the application, at least we've had access to data as it comes, which has sort of which has informed us how our CHWs are performing in the community, or basically how they're conducting their work. So this has helped us in terms of informed supervisions, both at the PIH office level, as well as at looking at the structure that we have in the community. And also the other thing has been on improved workflow support. Like for this application, in cases where say we have referred a client, or a CHW has referred a client to a facility, the application has a possibility of generating a task for a CHW to follow up on that potential client later on. So that has sort of improved the way CHWs also deliver their work. And another thing has been on over an increased different accompanies to facility. Of course, we can certainly attribute this to increase in coverage on the site since inception of Indanafe. Some of the key lessons that we have learned from this, like I mentioned, we're dealing with CHWs that are not really tech savvy. So there's need for continuous mentorship of users to ensure that whatever things we're upgrading in the application, they also stay up to date, and also just taking with them in terms of challenges that they're finding, and now we can also work on resolving those. The other thing is on the bugs that we also identify in the application. These basically affect users or the user experience. So one key thing that we've also learned is that there's need to continuously ensure that these are resolved, and also that they're resolved in good time, because basically if we have these things going on, they also affect the data that the CHType is input in the application. And also there's a need of continuous engagement with users, which basically also informs product and work for improvement, because this is where we also get most of the feedback from the users on the experience. Okay, so in terms of our next steps, we're transitioning to in-country self-hosting of the app and the database, just so we align with what the Ministry of Health in Malawi requires. And also we're in the process of finalizing work on open sourcing in an app, just so that we ensure that other implementers also have access to it, and they can also adapt the specific workflows according to their needs. And also the team is exploring on use of machine learning models to match records in the two systems. About to go in the verification phase on that, which will basically help or inform most of the work on interoperability between Indanafe and OpenMRS.